There's a switch inside almost every cell in your body, and when that switch works properly, sugar moves out of your blood and into your cells where it becomes energy. When that switch stops working properly, the sugar stays in your blood. Your pancreas notices. It produces more insulin to try to force the issue, and for a while, that compensation hides the problem completely. Blood tests look fine. Energy feels mostly normal. Nothing on the surface tells you anything is wrong. That switch is your insulin receptor, and the condition where it stops responding properly the way it should is called insulin resistance. Here's what almost nobody explains clearly. The most common medication used to manage blood sugar in the world does not fix that switch. It works somewhere else entirely, and understanding exactly where it works and where it doesn't changes how you think about the food on your plate. Today, we're going to walk through 5 ordinary foods sitting in ordinary grocery stores that researchers have studied specifically for their effect on this switch, not as a replacement for anything, as the missing piece of a much bigger picture. By the time we get to the 5th one, you'll understand something most people managing blood sugar issues are never told. Not because anyone is hiding it from you, but because a 12-minute appointment with your doctor simply isn't built for this kind of explanation. Let's start with what's actually happening inside your cells. Picture the surface of a muscle cell. Sitting on that surface is a receptor, a docking station built specifically for insulin. When insulin arrives and docks onto that receptor, it triggers a chain reaction inside the cell. That chain reaction opens a channel. Glucose flows in through that channel. Energy gets made, blood sugar drops. That's the system working exactly as it should. Insulin resistance means the docking still happens. Insulin is still arriving, your pancreas is still producing it, but the chain reaction inside the cell fires weakly. The channel opens part way, or sluggishly, or not at all. Glucose stays parked in your bloodstream, knocking on a door that won't fully open. 2 things drive this breakdown, and almost nobody outside of a research journal ever hears about either of them by name. The first is low-grade inflammation. Not the kind you feel, like a sore throat or a swollen ankle. A quiet, simmering kind that runs in the background for years. Inflammatory signaling molecules, researchers call them cytokines, 2 of the most studied being TNF-alpha and interleukin-6, interfere directly with the first protein in that chain reaction inside the cell, a protein called IRS1. When those molecules are elevated, IRS1 gets chemically tagged in a way that blunts its ability to pass the signal along. The door doesn't fully open. The second is a buildup of fat molecules called ceramides. These accumulate inside muscle and liver cells when there's chronic oxidative stress and a diet that runs heavy on certain saturated fats. Ceramides block a different protein further down the chain, one called AKT, which is essentially the master switch that tells the glucose channel to open. Block AKT, and it doesn't matter how much insulin showed up at the door stays shut. Here's the part that matters for what we're about to walk through. The most widely prescribed blood sugar medication in the world works mainly by telling your liver to release less glucose between meals. That's a genuinely useful effect. It lowers the number on the blood sugar meter. But it isn't acting on the inflammation-attacking IRS1, and it isn't acting on the ceramides blocking AKT. Those 2 mechanisms keep running in the background, mostly untouched, while the meter looks better. That's not a flaw in the medication. It simply wasn't designed to do that job. It was designed to do a different job, and it does that job well. What we're talking about today is the part of the picture sitting outside that job description. 5 foods, each one acting on a different piece of this mechanism, ranked, loosely, from the most indirect evidence to the most extensively studied. Let's begin. The first one, leafy greens, and the mineral almost nobody tracks. Spinach earns its place on this list almost entirely through one mineral, magnesium. Magnesium is involved in more than 300 separate enzyme reactions in your body. One of the most important, for our purposes, is an enzyme called insulin receptor tyrosine kinase. The specific step, right at the beginning of that chain reaction we just described, that gets the whole signal moving after insulin docks onto the receptor. When magnesium runs low, that enzyme works less efficiently. The very first domino in the chain falls weakly, and everything downstream from it inherits that weakness. Here's what makes this more than theory. Across a range of studies on people with type 2 diabetes, researchers have found magnesium deficiency in anywhere from roughly 1 in 7 to nearly half of patients, depending on the population studied and how strictly deficiency was defined. Some studies in patients with poorly controlled blood sugar have found it even more often than that. And across multiple studies, lower magnesium levels track consistently with a higher HOMA-IR score. That's the standard lab measurement of insulin resistance itself, not just blood sugar. 1 cup of cooked spinach delivers a meaningful share of your daily magnesium requirement, somewhere around a third of it, depending on which guideline you're using. It costs less than the price of a coffee at almost any grocery store in the country. Now here's an honest caveat, because this list is meant to inform you, not sell you. The evidence connecting magnesium to insulin signaling is strong and well established. The evidence connecting spinach specifically, as opposed to magnesium from any food source, to a measurable change in insulin sensitivity is thinner, because most of the actual clinical trials study magnesium supplementation, not spinach by itself. The mechanism is real. The food is a genuinely good way to get there. But spinach is doing its work indirectly, through the mineral it happens to be rich in, rather than through some unique compound only it contains. That's exactly why it sits at the more modest end of this list. Not because it doesn't matter, but because the case is built one layer removed from the vegetable itself. A practical note on preparation, because this trips people up constantly. Boiling spinach for an extended period leaches a portion of its magnesium and other minerals into the cooking water. A quick steam or a brief sauté in a little olive oil holds onto far more of it than a long boil, with the water poured down the drain afterward. If you take one thing from this section, let it be this. Magnesium-rich greens, eaten consistently, several times a week, are addressing a deficiency that close to a third of people managing type 2 diabetes are walking around with, most of them without ever having been told. The second one, the vegetable most people avoid for the wrong reason, okra. If your first reaction to that word is a slight grimace about the texture, you're not alone, and that reaction is exactly what's kept most people from ever learning what's inside this vegetable. The thick, slightly slippery substance released when you slice into an okra pod, the part most people try to cook away, is a complex of soluble plant fibers called mucilage. And that mucilage is the most clinically interesting part of the entire vegetable. Here's the mechanism. When that mucilage enters your digestive tract, it forms a viscous gel that physically slows down how quickly food moves through your small intestine. That slowing effect blunts the speed at which glucose from a meal gets absorbed into your bloodstream. Instead of a sharp spike after eating, you get a gentler, more gradual rise. And those sharp post-meal spikes are part of what feeds the inflammatory signaling we talked about earlier. So a gentler rise means less of that inflammatory fuel reaching your insulin receptors meal after meal. Okra also contains flavonoid compounds, including quercetin, which has been studied in laboratory and animal research for its ability to help move glucose transporter proteins, the actual physical channels that let glucose into cells, to the cell surface through a pathway that runs somewhat independently of the main insulin receptor signal. Now let's look at what the actual clinical research shows, because this is where I want to be precise with you rather than impressive. A systematic review and meta-analysis published in 2025 pooled 6 randomized controlled trials of okra supplementation in people with type 2 diabetes. The combined result, fasting blood glucose dropped by an average of roughly 21.7 milligrams per deciliter, and HbA1c, the longer-term blood sugar marker, dropped by about 0.42%, both statistically significant findings. Here's the honest part. That same analysis did not find a statistically significant effect on insulin levels or on HOMA-IR, the direct marker of insulin resistance across the pooled trials. So, okra's strongest, most consistent evidence is for blood sugar control itself, particularly after meals, rather than a clearly proven direct effect on the resistance mechanism. The mucilage slows absorption story is well supported. The deeper receptor level story is still building. That distinction matters, and I'd rather give it to you straight than oversell a vegetable. Okra earns its place on this list for genuinely reducing blood sugar swings through a clean, well-documented mechanism, just not necessarily for fixing the resistance itself, at least not yet, based on what's been measured so far. On preparation, the mucilage is fragile to certain cooking methods. Boiling okra for a long time and discarding the liquid washes much of that gel-forming fiber away. Quick roasting, a brief stir-fry, or slicing it thin and raw into a salad preserves far more of it than a long boil. Frozen okra is widely available and inexpensive nearly everywhere in the country. Fresh okra is easiest to find seasonally, particularly in the South. If this has been useful so far, a quick like helps more people come across this video, and genuinely, that's the only thing I'll ask of you today. Now let's keep going, because the next two foods are where the inflammation and ceramide story really comes into focus. The third one, the vegetable with the strongest mechanism for the part medication doesn't touch. Let's go back to those ceramides for a moment, because broccoli's case rests entirely on this mechanism, and it's worth understanding properly. Remember, ceramides are fat molecules that build up inside muscle and liver cells, and once they accumulate past a certain point, they block AKT, the master switch that opens the glucose channel. Your fasting insulin and HOMA-IR numbers are in large part a downstream readout of how much that switch is being blocked. Broccoli, and especially young broccoli sprouts, contain a compound called sulforaphane. Sulforaphane has been shown in research to reduce the activity of an enzyme involved in producing ceramides in the first place. Less ceramide production translates to less AKT blockage, which means the signal that's supposed to open the glucose channel has a better chance of actually getting through. There's real clinical data behind this one, not just laboratory mechanism. A randomized, double-blind, placebo-controlled trial published in the International Journal of Food Sciences and Nutrition gave 81 people with type 2 diabetes either 10 grams or 5 grams of broccoli sprout powder daily, or a placebo for 4 weeks. In the higher dose group, both fasting serum insulin and HOMA-IR dropped significantly compared to the placebo group. That's a genuinely meaningful finding, a measured drop in the insulin resistance index itself, not just blood sugar, from a food-based intervention over a relatively short period. Now, the honest update, because the research on this has continued since that 2012 trial. A more recent randomized, placebo-controlled study, published in Nature Microbiology in 2025, tested broccoli sprout extract in people with prediabetes over 12 weeks, and the effect was more modest than the earlier trial, and depended heavily on something nobody expected to matter this much: the specific composition of each person's gut bacteria. People whose gut microbiome was better suited to converting the plant compound in broccoli into active sulforaphane saw a meaningful benefit. People whose gut bacteria weren't set up for that conversion saw very little. That doesn't undo the earlier finding. It adds an important layer of nuance. The mechanism is real. The effect size in practice may vary meaningfully from person to person, for reasons researchers are still mapping out. Sulforaphane has a second job too. It activates a master antioxidant pathway in your cells called NRF2, which helps lower the oxidative stress that feeds the inflammatory signaling we talked about at the very start. So broccoli is doing double duty, chipping away at the ceramide problem and chipping away at the inflammation problem at the same time. A practical detail that actually matters here. Chopping raw broccoli releases an enzyme called myrosinase, which converts an inactive precursor compound into active sulforaphane. That conversion takes a few minutes at room temperature. If you chop broccoli and drop it immediately into boiling water, you can lose a substantial portion of that conversion before it has a chance to happen, because the heat deactivates the enzyme responsible for it. The fix is simple. Chop it, let it sit for about 10 minutes at room temperature, and then steam, roast, or stir-fry it. That short pause is doing real chemical work. Broccoli sprouts, sold in many grocery stores, often near the fresh herbs, contain dramatically more of the precursor compound per gram than mature broccoli florets. A spoonful raw on a salad gets you a meaningful dose without any cooking at all. The fourth one, the one nobody chooses for flavor: bitter melon. I'll say up front, most people who've tried it don't love it on the first attempt. But it has one of the longest and most studied histories of any food on this list when it comes to blood sugar. The research picture here is genuinely strong, but it's also mixed in an interesting and honest way, so let's walk through it properly rather than flattening it into a simple win. Multiple systematic reviews and meta-analyses, pooling dozens of trials all together, have consistently found that bitter melon supplementation produces a statistically significant reduction in fasting blood glucose. The effect on HbA1c specifically has been less consistent across studies. Some trials show a clear improvement, others show little change in that particular marker, even when fasting glucose improves. That kind of mixed result across markers is common in real nutrition research, and it's worth knowing rather than glossing over. The mechanisms researchers have identified are genuinely interesting. Bitter melon contains a peptide called polypeptide P, which laboratory studies describe as having an insulin mimetic effect, meaning it can act somewhat like insulin itself at the receptor level. It also contains compounds that activate AMPK, the same cellular energy sensing pathway that's central to how many blood sugar medications work, just reached through a different chemical doorway. And one well-known trial, comparing bitter melon directly to a low dose of metformin in people newly diagnosed with type 2 diabetes who hadn't started medication yet, found broadly comparable improvements in blood glucose over the study period, a genuinely notable head-to-head result, even though it was a relatively small study. A safety note that's important and often skipped entirely in content like this. Bitter melon is not considered safe during pregnancy, since some of its compounds have been associated with uterine contractions in traditional use in animal studies. It can also cause digestive upset in some people, especially at higher intakes. If you're pregnant or managing any condition beyond blood sugar, this is one to specifically run past your doctor before adding regularly. For everyone else, fresh bitter melon is easy to find at Indian, Southeast Asian, and Caribbean grocery stores across most of the country, usually for well under a few dollars per piece. The bitterness softens considerably when it's sliced thin, the seeds and pith removed, and it's stir-fried briefly with garlic and a little oil. Bitter melon powder, available at the same kinds of grocery stores, is a milder-tasting alternative for people who can't get past the texture or flavor of the fresh vegetable. The fifth one, the most thoroughly studied plant compound on this entire list. This last one isn't technically a vegetable. It's a compound extracted from the root of a plant called berberis, used in traditional Chinese and Ayurvedic medicine for thousands of years, and sold today, completely legally, in the supplement aisle of almost any pharmacy or big box store in America. Berberine has been studied in more randomized controlled trials for blood sugar and insulin resistance than nearly any other plant-derived compound on record. A systematic review and meta-analysis published in Frontiers in Endocrinology pooled 46 separate randomized controlled trials of berberine in people with type 2 diabetes. The combined results were striking. HbA1c dropped by an average of 0.73%, fasting plasma glucose dropped by about 0.86 millimoles per liter, 2-hour post-meal glucose dropped by about 1.26 millimoles per liter, fasting insulin dropped meaningfully, and HOMA-IR, again, the direct insulin resistance marker, dropped by an average of 0.71. Every one of those findings was statistically significant across the pooled data. The mechanism runs through the same AMPK pathway we just mentioned with bitter melon. And notably, it's the same pathway metformin itself activates, though by a different chemical route. Berberine also appears to increase the number of glucose transporter proteins available at the muscle cell surface, somewhat independent of how well the insulin receptor itself is signaling, and it slows the breakdown of complex carbohydrates in the small intestine, blunting the size of the glucose spike after a meal. There's a particularly notable study here, too, a trial published in the journal Metabolism that directly compared berberine to metformin in people newly diagnosed with type 2 diabetes who hadn't yet started any medication. Over 3 months, the two produced broadly comparable reductions in fasting blood glucose and HbA1c. That's a real peer-reviewed head-to-head comparison sitting in a journal that endocrinologists themselves read regularly. Now, here is the single most important caution in this entire video, and I want you to actually hear it rather than skim past it. Berberine lowers blood sugar through several real active mechanisms. If you're already taking metformin, a sulfonylurea, insulin, or any other blood sugar medication, adding berberine on top of that can compound the glucose-lowering effect, and in someone whose medication dose is already calibrated to their current diet and activity level, that combination has real potential to push blood sugar low enough to cause symptoms like shakiness, confusion, or dizziness. That risk is exactly why this is not something to start on your own without telling your doctor. This isn't a reason to avoid berberine. It's a reason to bring it up directly with whoever manages your diabetes care, so your blood sugar can be monitored a bit more closely in the first few weeks and your medication dose adjusted if needed. For a meaningful number of people, that adjustment downward is actually the goal, a sign the combined approach is working. But that's a decision for you and your doctor to make together, with real numbers in front of you, not something to figure out by trial and error at home. Research studies on berberine have typically used doses somewhere in the range of 300 to 500 milligrams, taken 2 or 3 times a day. I'm telling you that because it's useful context for the conversation you have with your doctor, not as an instruction to start taking it today. Let's bring this back together, because I don't want you walking away from this thinking the message is skip your medication and eat vegetables instead. That's not what the research says, and it's not what I'm telling you. Metformin, and medications like it, are doing real, measurable, important work, mainly by reducing how much glucose your liver releases between meals. That work matters. It's one of the most well-studied interventions in all of medicine, for good reason. What today's 5 foods are doing is different. Magnesium-rich greens are addressing an enzyme deficiency that affects a large share of people with type 2 diabetes, most of whom have never had their magnesium checked. Okra is slowing the speed of glucose absorption after meals through a well-documented fiber mechanism. Broccoli sprouts are chipping away at the ceramide buildup that blocks the master switch inside your cells, a mechanism most blood sugar medications were never built to touch. Bitter melon is acting through an insulin mimetic pathway and an energy sensing pathway, with real but mixed evidence depending on which marker you look at. And berberine is working through the very same energy sensing pathway metformin uses, through a different chemical door, with some of the strongest clinical evidence of any plant compound studied for this purpose. None of that is a case against your medication. It's a case for understanding that blood sugar control and insulin resistance, while related, aren't quite the same target, and that most treatment conversations, because of how little time a typical appointment allows, tend to focus almost entirely on the number on the meter rather than the mechanism underneath it. That's not because anyone is withholding anything from you. It's because a research finding published in a specialty journal this year takes time, sometimes years, to work its way into routine clinical guidelines, and an appointment built around 15 minutes simply isn't designed for a deep mechanistic conversation. The honest, useful thing to do with that gap is to walk into your next appointment with a specific, informed question, rather than to assume the worst about the person treating you. Here's a question worth asking at your next visit if you don't already track it. Ask whether your doctor can include a HOMA-IR calculation on your next lab panel. Most labs can calculate it from a standard fasting insulin and fasting glucose draw. It usually doesn't require any extra blood draw, just an additional calculation on results you're already getting. It's one of the few numbers that tells you directly whether insulin resistance itself is improving, rather than just the blood sugar reading on its own. And one more genuinely useful thing, while we're talking about working with your doctor rather than around them. If you've been on metformin for more than about 4 or 5 years, current research, including a large 2025 study using the National Institutes of Health's All of Us database, has found that long-term metformin use is associated with a meaningfully higher likelihood of vitamin B12 deficiency, which can, in some people, contribute to nerve-related symptoms that get mistaken for diabetic neuropathy. This is well known enough that diabetes guidelines actually recommend periodic B12 testing for long-term metformin users. It's a simple addition to a blood panel, it's not a reason to second-guess your medication, and it's the kind of small practical thing that's easy to miss, simply because nobody mentioned it. Before you go, have you actually tried adding any of these into your regular routine before? Or is this the first time you're hearing the mechanism behind a food you already eat? I'd genuinely like to know. Drop it in the comments. And while you're there, where are you watching from? Drop it in the comments below. I always like seeing how far this reaches. If you found this helpful and you want more breakdowns like this one, the actual mechanism behind the food, not just a list of recommendations, that's exactly what this channel is built around. I'm Dr. David Aid, and this channel exists for one simple reason: to take the research sitting in medical journals that most people never get handed in a doctor's office and explain it clearly enough that you can actually use it. Subscribe if that's useful to you, and I'll see you in the next one.